Good afternoon to everyone. Today, our grand round speaker is Dr. Adrian Semidey. As most of you know him, he's a native of Venezuela, and he finished his medical school and residency in Venezuela, and then did a surgical retina fellowship in McAllen, Texas. He joined KCASH in 2016, and currently he's a member at Vitreoretinal Division at KCASH and adjunct assistant professor at College of Medicine, Al Faisal University. Today, he's going to talk about crunch phenomenon. And now I want to leave the floor to Dr. Semidey to give us a detailed review of the crunch phenomenon. Go ahead, please, Dr. Semidey.
Thank you. Good afternoon, everybody. Warm welcome. When I was assigned this grand round a few months ago, I was hoping that we would be able to have it back in the auditorium and not this impersonal Zoom meetings. But you know, let's try to make the best out of it. So today, I wanted to focus the grand round lecture on a phenomenon that is seen relatively frequently in our practice, and which is always a cause for concern when dealing with patients with proliferative retinal disease. Okay, so first off, it is important to understand the history behind the term and how the treatments for proliferative diabetic retinopathy came to be. We all know that diabetic retinopathy is the primary cause for vision loss in the working age population, and around 60% of diabetic patients will eventually progress into proliferative diabetic retinopathy. And once this happens, vitreous hemorrhage, tractional retinal detachments can be the cause. Unfortunately, the visual prognosis is uncertain despite intervention. Special attention must be placed on the burden that all these elements can have on healthcare systems, patients' lifestyle, their own economy, their family life, etc. So all these uncertainties resulted in an effort to determine what could be done to prevent this visual compromise. And the diabetic retinopathy study began in the early 1970s. And their primary question was, could panretinal photocoagulation prevent severe visual acuity loss in patients with PDR or severe NPDR in both eyes? So basically, one eye was randomized into the study and the other one was observed. And those that were randomized into the study received either argon or xenon laser panretinal photocoagulation. After around 5 years of including patients in the study, they concluded that panretinal photocoagulation could reduce the risk of severe vision loss by at least 50% of the patient compared to the untreated control eyes. But the greatest benefit was seen in patients with high-risk proliferative diabetic retinopathy. This has been, for many decades, the mainstay of therapy, as we all know very well. However, as multiple studies began to assess treatments for the diabetic macular edema part, more specifically with anti-VEGF, the first to notice a possible regression of PDR once intravitreal anti-VEGF agents were injected into the eye were the RIDE and RISE studies. And they were evaluating the efficacy and safety of ranibizumab or Lucentis for diabetic macular edema. This theory was later expanded on in the DRCR NETS Protocol S, where they directly compared ranibizumab versus panretinal photocoagulation for PDR regression. They had similar or equivalent outcomes with both treatment modalities, but the ranibizumab group had better visual acuity outcomes in patients who had baseline diabetic macular edema. They also found that there was a less of a need for eventual pars plana vitrectomy in patients that were receiving ranibizumab. Later on, seeing these findings, other drugs like bevacizumab or Eylea were similarly compared in other studies. So this finding that we could now treat proliferative diabetic retinopathy with the adoption of the anti-VEGF agents as an alternative treatment for proliferative diabetic retinopathy. Let's recall that panretinal photocoagulation back in the diabetic retinopathy study was severely painful. It took several sittings to complete, and there was a significant reduction of the visual field after the patients had been ablated, after the retina had been ablated. There was also secondary risk of developing diabetic macular edema after treatment, risk of vitreous hemorrhage, and eventual progression of the TRD, even with panretinal photocoagulation. So the alternative of having anti-VEGF agents seemed wonderful. Now, as this tendency grew of utilizing these anti-VEGF agents, so did the concern in complications that were presenting, and that the disease was progressing despite having received anti-VEGF agents, or that the disease was progressing because they had received anti-VEGF. So this is how the term crunch phenomenon was coined. It's a general term that is used to define the progression of tractional retinal detachments after the injection of anti-VEGF agents, but it has also been used to describe progression after panretinal photocoagulation. It's also known as a crunch effect, crunch syndrome, ROP crunch, and anti-VEGF crunch. The literature, as I mentioned previously, has also documented the progression of tractional retinal detachments after panretinal photocoagulation. And although this term has been used in PDR, ROP, and other diseases like we can see here, today we'll focus mainly on proliferative diabetic retinopathy. So the first investigators to document these findings back in 2008 were a group led by Arevalo and collaborators, and they studied the rates of tractional retinal detachments after intravitreal Avastin was administered. So let's keep in mind that these were patients that were scheduled for vitrectomy because of proliferative diabetic retinopathy or proliferative tractional retinal detachments or vitreous hemorrhage. So their inclusion criteria was that they used intravitreal bevacizumab before patients in whom the use of IV Avastin was used before vitrectomy for management of proliferative diabetic retinopathy. However, they included patients with tractional retinal detachments, pre-existing tractional retinal detachments, persistent vitreous hemorrhage, and incomplete regression of the disease despite panretinal photocoagulation being administered, to the development of a new TRD or the progression of a pre-existing TRD. They also documented cases in which there was worsening of the vitreous hemorrhage. This we'll talk about in a few slides. That it's important to notice in this square down below the time from the moment these patients were injected until the development of progression, but we'll expand on this in a while. Now, these findings that Arevalo reported caused significant concern amongst clinicians, and over the following years, many reports came out documenting the incidence of this crunch effect, specifically in PDR. Last year, a review article published by Tan and collaborators focused all of these previous reports. And most importantly, they were able to establish all the limitations that these studies had. For example, most of them were retrospective and most of them were single-armed. They lacked a control arm, and the only prospective study was also lacking a control group, and they had a small sample size of 18 patients only. One big issue that they found was that all these studies enrolled a heterogeneous group of patients. And this was a significant issue, since some patients presented with vitreous hemorrhage, others had pre-existing fibrovascular changes, like a ring-like contraction over the macula, lack of previous panretinal photocoagulation, high-risk PDR, etc. So we could establish that whether or not these patients received anti-VEGF, they were predisposed into progressing into a TRD just because of their baseline disease. Another significant issue was that they did not have standardized imaging. Fundus photos were not clear on occasion due to the presence of vitreous hemorrhage, nor were they or the B scans standardized. This brings into consideration that many of these cases, were being categorized as progression based solely on the clinical judgment of the ophthalmologist. And this gives into the subjective nature of all their evaluations. As I mentioned previously, the variable time frame from intravitreal injections to pars plana vitrectomy is a concern. For example, in Arevalo's 2008 series, more than 50% of the patients had passed more than 12 days since the time of the injection until the documentation of the complication. And this is something that is not regular in practice, clinical setting. And they took all patients from the protocols I, protocol J, and S and T from the DRCR net. And these patients were not scheduled to undergo vitrectomy, unlike the series published by Arevalo. And they compared them to a control group of patients included in the same trials who were randomized to receive either PRP or sham injections. Patients who were receiving steroids were excluded from this study, from this review. So, So they did take into account, and they excluded any patients who had a macula threatening or macula involved tractional retinal detachments. And their primary outcome, however, if the patients did have an extramacular TRD and some of them had vitreous hemorrhage, they were included in the study. Their primary outcome was to determine how many of these patients would develop tractional retinal detachments within 12 months, or how many of them would require a TRD surgery within PPV, for a TRD within 12 months of the inclusion. Their result was that the control group, which received laser or sham, 6.8% of the patients would develop into traction, whereas in the anti-VEGF group, only 4.8% of them developed traction over this period of time. However, we need to take into account that the anti-VEGF most commonly used in all these protocols from the DRCR net was ranibizumab. They were focused mainly on that, and only about 80 out of these 500 patients who received injection were receiving either Avastin or Eylea. And as you can see in the table down below, most of the cases were that developed eventual traction were patients with high-risk PDR. So, although it was suspected, several theories emerged on how this happened. And the first was a group from Netherlands that believed that there was a direct correlation between the levels of VEGF and connective tissue growth factor, which is CTGF. So they measured the levels of CTGF and VEGF by ELISA in patients in 52 vitreous samples of patients that were undergoing pars plana vitrectomy for PDR pathology. 24 of these patients had received Avastin. And they correlated these levels with the degree of fibrosis, of vitreoretinal fibrosis, as they had determined clinically and intraoperatively. They were able to conclude that there was a ratio between connective tissue growth factor and vascular endothelial growth factor, and it is a strong predictor of vitreoretinal fibrosis in PDR. And this showed that intravitreal anti-VEGF treatment caused the increased fibrosis in these diabetic patients. This would imply that connective tissue growth factor levels, connective tissue growth factor levels, or decreasing vascular endothelial growth factor levels would shift the balance between CTGF and VEGF. And this would cause a switch between the level of neovascularization and pushing it towards a more fibrotic state. So here I have a small schematic of the angiofibrotic switch theory. So basically we have a microenvironment that has ischemia, right? And this is typical in all proliferative retinal disease. So if we have, let me see if I can mark this. Yeah. So VEGF released in a state of ischemia will lead to neovascularization. But as VEGF levels drop, more CTGF is produced or becomes more predominant. And this allows the formation of fibrosis. So this switch from neovascularization and decreasing the VEGF levels would eventually allow CTGF levels to dominate and develop fibrosis. This is what is called the angiofibrotic switch. And this is led by anti-VEGF medication in these patients. Another model proposed by Nakao and collaborators determined that VEGF inhibition upregulates the expression of transforming growth factor beta. And this in turn contracts blood vessels, affecting the fibrovascular membrane microstructure and promoting fibrosis. Wait a second, but what about panretinal photocoagulation? Well, if we think about the mechanism of action of panretinal photocoagulation and knowing that we have a reduction in blood flow and hypoxia that leads to increased levels of VEGF in the retina and vitreous, and that the objective of laser treatment is to precisely destroy the photoreceptors and to reduce oxygen consumption by the photoreceptors so that the oxygen from the choriocapillaris can penetrate into the mid and inner retinal layers. And this is the whole purpose of panretinal photocoagulation, right? To supply a balance between the supply and demand of oxygen. So if we take our previous model and we substitute the VEGF, the PRP for VEGF, we see that we're having exactly the same mechanism. We have an ischemic setting that will lead to the production of VEGF and eventually develop neovascularization. And when we administer PRP, we're also switching that angiofibrotic change from a VEGF predominant level into a CTGF predominant level, hence developing fibrosis. Now, we do need to take into account that PRP will cause this decrease in VEGF levels much more slowly than VEGF, where it would happen basically in a couple of days to a couple of weeks. So let's take a minute to put things into perspective now that we have these results. We have some retrospective analysis, and in their cases, we had an incidence ranging between 1.5% to 18% of patients who were receiving anti-VEGF developed eventually a crunch phenomenon. And in the more controlled setting of the DRCR pooled data, their result was that roughly 4.8% of patients that were receiving injections would develop a tractional component within a year. So if we apply this data to our setting and doing roughly 100 injections a day, 5 days a week, 20 days a month, this is basically 2,000 patients a month. And if we extrapolate this data to our setting, this would mean that about 100 of our patients each month would be progressing within a year into a proliferative state that would require surgical resolution. However, if we also take into account that the DRCR net pool, where 6.8% of the patients that were in the sham or the control group receiving sham or panretinal photocoagulation, this would mean that about 140% of about 140 patients, from our setting would also develop TRDs within a year. So analyzing this, basically, if we inject or if we treat with panretinal photocoagulation, there's about a 5 to 7% chance that these patients will progress just because of their baseline disease. Now, what about crunch in other retinal disease? Well, as I mentioned earlier, anti-VEGF crunch has been described in a number of other retinal conditions, including ROP, EOS disease, FIVR, and Coates disease. So in a 2011 Retina Today article, Paul Chan was one of the first to coin the term ROP crunch. So many investigations were being reported at that time because that's when the BEAT ROP results began to come out and they started to see their complications. So despite receiving anti-VEGF, some of these babies were progressing into TRDs. And the main conclusion that they came to was that timing is essential. If we inject anti-VEGF too early in ROP, we're going to result in a delay in normal retinal vascularization. But if it was used too late and there was already traction present on the retina, these cases could progress into a TRD. And this was studied in more detail in a 5-year retrospective analysis of ROP treatment eyes. And they had 28 patients with type 1 ROP. They were elected to have either panretinal photocoagulation, which was given in 32 eyes of 16 patients, or intravitreal bevacizumab, which was given in 22 eyes of 11 patients. None of the Avastin eyes progressed into a TRD. However, one in the PRP eye eventually developed crunch. Another multinational group pooled together patients that had received intravitreal bevacizumab or intravitreal ranibizumab for type 1 ROP, and that they had eventually developed TRD. Their main goal was to establish a time frame between the moment of the intravitreal injection and the development of a TRD. And they found that about 11% of the patients would develop a TRD within a week of the injection, 23% would develop a TRD within 2 weeks, and around 50% of the patients would develop TRD within a month of the injection. Another disease that has been studied, or that has been, or where the crunch phenomenon has been described, there is Coates disease. There's one report of patients receiving ranibizumab for either stage 3B or stage 4 Coates disease. And they concluded that one of the 9 eyes that were studied eventually developed a TRD. This is only like 11%. And this happened after a 9-month follow-up. Unfortunately, this patient also developed ptysis eventually. Another report about Coates disease mentioned the analysis of 8 patients, in this case with stage 2, 3A, or 3B. But their incidence was much higher. They found that around 4 eyes, or 50% of the eyes of the patients, eventually developed fibrosis and tractional retinal detachment. There's other conditions where, as I mentioned, that crunch has been described. For example, Anneal's disease. This was an interesting study of it. This was actually a prospective study for the treatment of non-clearing vitreous hemorrhage attributed to Eales disease. And they randomized 20 patients into receiving either Avastin or observation for the management of their vitreous hemorrhage. And they found that in the Avastin eyes, around 30% would eventually develop a TRD, requiring PPV and guarded visual prognosis, whereas 0 of the eyes that were observed would eventually develop a proliferative tractional retinal detachment. A FIVR is a much less studied disease in regards to crunch, and there's only one report, and this is from a long time ago, and they were actually studying IV pegaptinib or Macogen, which we don't use much now, for exudation secondary to fever that was not responding to conventional treatment. And one of these patients developed a TRD. So in summary, we have learned that any situation that causes a rather abrupt decrease in VEGF levels and thus increasing the ratio between CTGF and VEGF can lead to a crunch episode. Therefore, any disease that has the potential to produce VEGF can eventually be susceptible to crunch. We can also infer that any treatment that we apply to a patient that can eventually reduce VEGF levels and shift the ratio can also lead to a crunch phenomenon, albeit if it's anti-VEGF or if it's panretinal photocoagulation. As clinicians, we need to understand the potential risk factor that can predispose a patient to crunch. Throughout all the case reports and papers, the most common risk factors were the presence of a ring-shaped or a ring-like fibrovascular contraction over the posterior pole, severe retinal ischemia, or the absence of previous PRP, because we could imagine that these patients have higher VEGF levels, correct? And high-risk PDR was also established as a risk factor. Also, if we allow for a long period of time to pass between the moment of injection until surgery, this will lead also to a higher incidence of crunch. This is why I believed it was important to have this lecture. Anti-VEGF are widely used for DME, and the treatment nowadays is administered by any ophthalmologist, sometimes residents in training, fellows, and in some countries, they even have nurses and optometrists performing the injections. We also have to consider that our setting is a little different than those in large multi-center trials. Our patients are not regularly followed up. They usually have a poor systemic metabolic control and our high patient volume we need to take into consideration. And with this message, I want to conclude. We have to learn that we need to treat the fundus of the patient and not the OCT. We need to take the time to examine the entire fundus of these patients instead of only looking at the OCT. We understand that we have high patient volumes, as I mentioned previously, but we cannot limit ourselves to the 6 millimeters scan that we can see on the OCT. A small message that I have here to finish is that, you know, as healthcare workers, all of us, we need to remind ourselves that not all disease can be diagnosed and not all that is diagnosed can be treated. Even when we're allowed to treat or when we can, not everything that we treat, we can cure. But all patients can be heard, comprehended, alleviated, and accompanied. And this will make a huge difference in their lives. Thank you.
Okay. Thank you, Dr. Semidey, for your nice presentation. You refreshed our memory about the syndrome. Now I'm opening the floor for discussion. Is there anybody who wants to add anything?
Yes, I have a comment.
Yes.
Thank you very much, Dr. Semidey. I'm Dr. Saleh Al-Amro. And now,
Hi.
Hi, nice, very nice lecture, enlightening. The other thing that I think, if you see the reports of crunch after this phase of proliferative diseases, what I think that this sort of has been sort of magnified. And what I would suggest that take it, put it in the back of our mind. But now let us say that we shouldn't, this shouldn't prevent us from doing the proper management, especially in two situations. One is in ROP. I think now the disease, if we leave the disease, we know when it reaches threshold or type 1, the recommendation is to treat. And the alternative to anti-VEGF is the laser. And we know the differences between the two, and we prefer this. And in fact, in the, our national program, we prefer for many reasons the anti-VEGF. But this shouldn't prevent us from delivering the thing. Don't delay it until there are start of fibrosis. And in fact, weighing things, because we have been seeing traction detachment in ROP even way before this anti-VEGF and way before even the laser and the curve. So now the problem with these studies is, you mentioned it very much about the limitations of these studies. And the other case where we shouldn't put a lot of weight on the crunch is the pre-op use of anti-VEGF, especially in proliferative diabetic retinopathy. Now, in the days before anti-VEGF, we had problems operating on these PDR and traction detachment. You see, we spend a lot of time controlling the bleeding of these vasoproliferative membrane. And sometimes we had so severe intraoperative bleeding. Yeah, it is a mess, in fact. And I don't know, I don't see much of your gray hair as mine, but if you had these problems, we shouldn't hesitate. I think one of the major uses of anti-VEGF, in fact, is preoperative preparation of these vasoproliferative problems, especially PDR. It will make it really easy. And well, if the patient misses the appointment, delayed, we have seen patients injected and nothing happened, and we have seen patients that are left alone and they develop. The problem is that now most of these patients are biased, and this is sort of uncontrolled bias, because you have the setup of non-perfusion, you have the setup of sort of natural progression from these new blood vessels to the cicatrization effect because of the CT VEGF. So you cannot say that is this natural or secondary to anti-VEGF or secondary to laser in case of PRD. I think maybe a little bit of sudden decrease and of anti-VEGF, sudden increase of CT VEGF may play a little role, in fact. But now also this is, I think, the same. Is it sort of just progression of the normal physiology or pathology here, or this is induced by these? Like what happened that now after cataract extraction with complications and then the retinal detachment. Is it due to, this is due to, will be the BVD induction, most of if it's tear related. But if now let this patient let alone and develop BVD, will this also cause the tear and detachment? And just we made it to happen earlier, or he will not have the pathologic BVD just because at that time and because of the earlier incidents, we made it from physiologic to pathologic. And I think this is an area for discussion, but we shouldn't, it shouldn't prevent us from giving this agent in sort of critical situations. I would love to hear your comment and others' comment as well. Thank you.
Thank you so much. That was a wonderful intervention, because you're absolutely right. No matter what we do for these patients, the natural course of the disease is to shift from a neovascular presentation or manifestation into a cicatricial or fibrotic development. However, when we do the anti-VEGF injections or when we do panretinal photocoagulation, this will happen faster in VEGF patients, a little slower in PRP, but it is basically the natural course of the disease. In that, there was a slide where I presented the protocol, the DRCRnet protocols, where they established that around 4.8% of the patients would go within a year into TRD, and then all the retrospective cases, around 5% of those would also go into TRD. But when we compare that to the control group, which are patients that are getting sham, which is nothing, they're just observing them, or patients that were getting laser, they had actually a higher risk of going into, they were around 6.8% of going into traction within a year. So it's basically the natural course. And we also have to keep in mind that back when all those retrospective case series appeared, they were just discovering anti-VEGF for precisely preoperative use. And that's why Arevalo and their group, they have been injecting patients for a few years. But I think the time frame between the injection and surgery was not very clear yet. That's why more than 50% of their patients passed more than 12 days between the moment of the injection until surgery. So nowadays, it's an invaluable resource that we have, especially in our setting, that we have all these proliferative or all these young tractional patients. I cannot imagine what you guys had to go through trying to do surgery or attempting that with without proper hemostatic control that the Avastin can give us. Absolutely. And ROP, it's very clear. The first analysis that came out, they said if we inject too early, we're going to slow down the natural vascularization of the retina. However, if we already have tractional presence, then we're at higher risk of developing TRD. I don't know what your experience is in ROP. Do you inject when you begin to see traction on the retina, or would you rather just go with conventional laser ablation?
In fact, these are, as you know, the anti-VEGF for ROP are quite new. But now also there are sort of personal choices in this matter. But now, in fact, I lean more that because also the PRP will cause the reduction sort of maybe not as sudden as anti-VEGF, but it will also cause the reduction of VEGF and the increase of the CT VEGF. And the other thing that, in fact, I don't mind because one mentioned that one of the risk factors is when you have like the wolf appearance and this. But this, I think, this is also a risk factor for the natural progression, even without any injection, without any laser, as I'm sure that this is your experience. So myself, I'm not that much of sort of preventing this from getting the injection, just because we will delay them to get the laser. And in fact, this is probably more dangerous than getting the injection itself. But very difficult to say now, because in our program, it is more mainly sort of a personal choice rather than to dictate on the practicing physician.
Absolutely. I think that in our setting, the last message I gave, where we have to treat the fundus and not the OCT, is the most important, because if you evaluate your fundus and you see you have traction and this patient's scheduled for surgery, there's no harm. Go ahead and inject him. You'll just make your life easier, and he's still going to need surgery within a year. As we saw, that is basically a natural progression. But if we're just treating OCTs and we're just opening the OCT and checking the horizontal raster, we're not really seeing what's happening outside the posterior pole. And that is the main problem, because like you said, if you have a patient you're following up in clinic and he has a big fibrotic plaque over the macula, you're never going to inject this patient unless you're planning on taking him to surgery. It would be unheard of. So, I think a good clinical exam, and this is something that we have to focus on, will prevent, a lot of these complications.
Yes, you are right. But now, if you see a patient with a large front of gliotic tissue, probably this patient doesn't need sort of this our intervention, because this is his natural from Allah, the regression of the disease. And
yes.
Maybe our intervention, even just disturbing the vitreous, will cause more problem than benefit.
No, and sometimes we also have patients that have already shifted from a neovascular presentation into a fibrotic presentation, and for years they have these inactive membranes. Basically, the theory is telling us that this is safe to inject them. They're not going to switch because they're not vascular. They've already become fibrotic. So these patients, if you're planning on following them up closely, of course, then yes, you can, and they have macular edema associated to old inactive traction, then injections can be an option, of course, as long as they're being followed up closely.
Yeah, I would agree.
Thank you so much for your intervention. Appreciate it.
Thank you as well. Nice presentation.
Thank you.
I think if nobody has anything to add, we can finish the session. Thanks, Dr. Semidey.
Dr. Semidey, thank you for this wonderful presentation. I have a question regarding advanced cases in a new vascular glaucoma, for example. Sometimes you have aggressive posterior pole fibrotic membranes, And we need to inject to obliterate the anterior chamber, new vessels or anterior segment, new vessels on the iris. So there are few reports that reported successful disappearance of these new vessels after intracameral anti-VEGF injections. Do you think the intracameral anti-VEGF will have less effect than the intravitreal membrane in such cases?
Yeah. Well, that's what we generally do in practice. If we're unable to laser these patients, either because they have high FEMA or they have a dense cataract or a non-dilating pupil, and you cannot guarantee that you will laser them, then and they have tractional membranes on the B scan, then it's safer just to give intracameral anti-VEGF. This to reduce the neovascularization of the anterior segment. This will do very little to what's happening in the back of the eye. So you're going to reduce your aqueous levels of VEGF, but probably the vitreal levels will stay the same. So the purpose, I think, of injecting them intracamerally is just to hold off the neovascularization and stop the bleeding and give us some time, hopefully, to be able to do a proper a washout or a proper vitrectomy and dealing with the pathology which is coming from the posterior pole. So yeah, in my experience, I think intracameral is great, but this is only a temporary measure. Eventually, these patients are going to need either laser or surgery to deal with their baseline disease, which is retinal ischemia.
Is there any other questions? Okay, thanks, Dr. Semidey.
Thank you.